small. This is extremely important, especially for a beginner. What I mean to say with that is, the target point should be in the center of the fluoroscopic image, and you should be able to identify one level above and one level below. In the AP or oblique view, especially if you're doing at the lumbar level, the AP or oblique will sort of give you the direction of the needle, not the depth of the needle. So that is one D. So if you want to know the depth of the needle, you have to go to lateral position, lateral view, and then get the depth. If the depth is not right, especially if you're a beginner, even for me, even now I do that, then go back to the AP or oblique view and confirm that the direction is correct, and then check the depth again. So it is direction, depth, and direction. That's what is called 3D principles. Challenges. It's quite challenging when you're doing fluoroscopic procedures. Now here, it appears everything messed up here because there are osteophytes. You can see here there's an osteophyte at L5 and S1 level, this osteophyte here. So you don't know where to go. That is the pedicle there, and that's my needle there. I'm using a subpedicular technique there. So the important thing is, I think Dr. Kumar discussed anatomy just a few minutes ago. And other speakers, Dr. Parvesh and Palak, have also discussed very well there. Yeah? Square the vertebral end plate closest to the target point as much as you can, preferably a perfect sort of end plate picture. In that picture, identify the pedicles. So this is a true AP view with a 5 or 7 degrees cephalic tilt at the lower lumbar levels. If it is higher lumbar levels, you go caudal tilt. If it is thoracic or lumbar, you do continuous fluoroscopy and see how you can square the disc. Same in the cervical spine, also if you're doing the prone position. Yeah? So in this, but true lateral view will be the spinous, true AP view will be spinous process, the center of the two pedicles. Once you've done that, identify the structures. Yeah, one by one. Even now I do this because it can be confusing, especially if patients have spondylolisthesis, osteoporosis, and scoliosis. If you're having difficulty identifying the target point, look at one target point above, one target point below, and draw a line. You'll start seeing, because it's not visible. As I said, bones are our eyes, so you need to see your target point. On 2 occasions, I could not see the target point of cervical level. I cancel the procedure. If you can't see, you can't see. You can't do anything. Come, get help.
YLD for low back pain was 64.9 million years in 2017. There is no lack of treatment option available for low back pain, but what we lack is specific diagnosis of patient chief complaints. Before we understand the pathology of lumbar disc disease, we have to understand what is the natural history of degenerative disc disease. All spine starts showing signs of degeneration as part of aging, and this degeneration starts as early as age 20. Our L4, L5, L6, S1, this starts showing signs of degeneration at very early age. And current treatment modality are for symptom relief only, they are not for cure, because they can't stop the process of degeneration. And each spinal segment degenerate at different rate. L4, L5 may be advanced stage of degeneration, while L1, L2 may be initial stages of degeneration. And this aging and degeneration process usually goes on silently, asymptomatically, without any pain, but sometimes it becomes complicated by herniation, instability, and stenosis. So there are 3-4 entities which can complicate this normal degenerative process. But fortunately, majority of this complication can be treated conservatively. Surgery is rarely required, and so natural history of disc degenerative disease is extremely favorable. We divide the stages of degeneration into 3 stages. One is stage of dysfunction. This starts at the age of 15 to 45. There is a fissure in the annulus, and there is a synovitis of the facet joint. The next stage is instability. It starts at 35 to 17 when there is absorption of the nucleus. Nucleus is very hydrated. It has lots of water content, but slowly this starts showing signs of desiccation, the resorption of the nucleus and decrease the disc space. And along with that, there is a degeneration of the flexor joint. Flexors and discs, these are moving motion segments. And then start the stage of stabilization, when body tries to stabilize the whole thing by forming new bond around the flexor joint, around the bone, which we look at as an accident osteophytes. So it starts after age of 60. Hypertrophic bone around the disc and the flexor joint. So these processes, they are going asymptomatically, but sometimes they can be complicated. We have two complications including stage of dysfunction and stability, what is called internal disc derangement and disc herniation. And we have two complications during stage of stabilization, what is called a degenerative lysis and spinal canal stenosis. So according to this study, we have identified the only 4 entities where we can label the patient that this patient is suffering from IDD, disc herniation, lysis or spinal canal stenosis. So there are 4 entities in which we can label a diagnosis. So we discuss one by one. So this is the first slide. This is the first stage of degeneration. You see, this is what is known as the black disc syndrome. There is a you see on T2 images, the L3 and L4 is very hydrated.
The MRI scan, 95% of patients, the MRI scan will show normal, but still they will have a sacral joint pain. The diagnosis I use is pain can be there all over, but more significantly below L5 level. Women, maybe unilateral, maybe bilateral, more commonly unilateral, and pain over the sacral joint in the posterior like spine. I don't use the tests what are recommended in healthcare. The most important is diagnostic block. I had some local destroyed. Coming to your question, is dye injecting important? In my opinion, my experience shows that I use only about 2 ml of 0.25% bupivacaine, because if I use 0.5, sometimes it can leak and that delays the patient's discharge. And I cannot afford that. That leads to other things. So I use 2 ml of 0.25% marcaine or bupivacaine with 20 to 40 milligrams triamcinolone, because it's less and I inject about 0.2, 0.3 ml of contrast. And I always nowadays use double needle technique because that gives me 2 chances of getting it right. And if you inject in periarticular, you inject large volume. You inject reasonably large volume. So it will spread everywhere. So if you inject contrast, you will know where it's going. You inject half ml of contrast, you see the spread there. You will be surprised. So my technique has been that I inject contrast and then only inject the low volume, low density and stored mixture. And as I said, even using double needle technique in 10%, I can't be inside. Yeah? In those cases also I use low volume and hope for less.
So it is like you are able to inject 2 ml.
Oh yeah. 2 ml, 2.5, 3 ml. Lot of pressure. If you're in the right place, it is so difficult to inject. No. Yes and no. Yeah. It can be painful. You're absolutely correct. But the important thing is, it is a diagnostic block, and if you add a small amount of thread, it can become a therapeutic block. So assess the patient. What I do in my practice is assess the patient before the procedure, even for medial branch block, whatever it is. Ask them to imagine the pain they have as 100% or 10 out of 10. Ask them to do all the movements that causes pain. And then before discharge, I will see the patient, every patient, and ask them to do those things, and ask them how much pain relief they have had. Because when they come to you, they are forgotten. They'll tell you, put something about it. That time you record, and you give them a form. This is your pain, mark this and come back to you, come get that. Then you get the diagnostic element before you go. Then I record on the system that 80% pain relief. What is 80, what is 70, what is 60? God only knows.
Sorry to interrupt, sir. I think it was a wonderful session. All speakers.
So my aim today is to narrow down the differential diagnosis by means of a detailed clinical history and examination. Hip joint, as you all know, is a ball and socket type of joint, and it has got a cartilage inside, and the acetabular rim is covered with a labrum, which gives more stability to the multi-axial motion that is possible. The motion that is possible, the range of motion is second next to the glenohumeral joint, so it is more prone for trauma and pain. And it is a major weight-bearing joint which transfers the load from the upper body to the lower body. There are varied pain generators, as told by my earlier speakers. The pain generators might be intra-articular pain generators or extra-articular pain generators. Coming to the intra-articular pain generators, it may be originating from the articular cartilage in case of osteoarthritis. The synovium might be a source of pain in the case of inflammatory arthritis. There may be an acute labral tear which can cause pain, and sometimes there can be a Cam's deformity or a pincer deformity in the bones that can cause an impingement that leads on to pain. There can also be avascular necrosis or stress fractures in the bone that can be a source of pain. The extra-articular pain generators being the muscles. There are a lot of muscles because the hip joint is a highly mobile joint. There are lots of major muscles like iliopsoas, piriformis, and gluteus muscles. All these muscles, any degeneration or tear in these muscles can be a source of pain. There are varied bursae, tendons around the joint that can be a source of pain. And never forget that there can be pain because of referred pain from the intrapelvic and abdominal structures. So that is also possible. Whenever your clinical examination doesn't match with whatever patient is complaining, always examine the abdomen as well. And majority of the patients with low back pain and sacroiliac joint pain do have referred pain in the anterior hip. So this picture shows the importance of differentiating the pathologies. Any patient who is coming with an anterior hip pain might have a hip pathology, hip joint pathology per se. But any patient who has a deep groin pain, 45% of patients with deep groin pain have SI joint dysfunction as well. So this stresses the importance of evaluating the back as well as the SI joint. Around 8 to 10% of the patients with lumbar spine disease, particularly those with the L4, L5 or L5S1 disc bulge, degenerative disc, they can cause hip pain, deep groin pain. Coming to the topic per se, clinical evaluation of hip pain, with a focused history and the physical examination of the patient, we can definitely narrow down the diagnosis, clinical diagnosis. So the first thing would be to ask for a detailed history, rule out any red flags like trauma, tumor, or any fracture, and then going for a physical examination. And I will also stress on the investigations, including diagnostic injections, because sometimes it may be confusing. The pain may be arising from the hip joint or from the sacroiliac joint or from the facet joint. So we may not be sure. In such cases, we can go for diagnostic injections, and almost always the treatment plan should be based on the impact of the pain on the life of the particular patient and what expected goal is there for the patient. Coming to the focused history, with the age and the site of pain alone, we can definitely narrow down the diagnosis. For example, if a patient is a young athlete who is coming with an acute pain following a sport, then you have to suspect a muscle tear or a labral tear. Whereas in an elderly patient who has had pain on weight, the diagnosis may be more towards an osteoarthritis of the hip. So based on age and site of location, site of the pain also, because if it is a deep groin pain or if it is an anterior hip pain, majority of the time the diagnosis might be an osteoarthritis of the hip, or it may be an iliopsoas muscle tear, or it may be some intra-abdominal pathology causing a referred pain. Sometimes it can be a sacroiliac joint pain. So with the age and the site of pain is very, very relevant, important in coming to narrowing down your diagnosis. The onset of pain, duration, quality, severity of pain all needs to be documented. Previous history of trauma or injury and questions relevant to hip joint function. There are certain questions like whether the patient is able to get out of the car easily or get inside the car easily, whether he is able to wear his socks by himself, whether he is able to climb up the stairs or down the stairs. These are all certain questions which we need to document before going for any further diagnostic methods. And specific aggravating and relieving factors might be there depending on the pathology. For example, if the patient is having a lateral hip pain and is not able to lie down on the same side, that might denote a bursitis, trochanteric bursitis on the same side. There can be radiation to leg. Radiation to leg is important because there can be other coexisting lumbar spine issues. And some patients might complain of a lock or a snap kind of thing in the extremes of movement that may be pointing towards snapping hip syndrome. And the past history of any similar illness, back pain or radiating pain, and the medical, surgical and personal history is very, very important, because sometimes patients with long-term corticosteroid use, patients with smoking and alcohol, they can develop a avascular necrosis of the hip, which may be the primary source for the pain. All these are relevant history which needs to be documented, and any prior treatment history has to be noted. Coming next to the site of pain, based on the site of pain, we can classify hip pain as anterior hip pain or deep groin pain, which is shown here in this picture. This is the anterior hip pain or deep groin pain. The pain can be a lateral hip pain or it can be posterior hip pain. So the pain pattern, this picture shows the varied pain patterns in various disorders. See, if you look at this picture, this shows the hip pain per se. But this just looks like that of the sacroiliac joint pain or the lumbar pain, lumbar disc pain. If you look closely, most often the patients will have a pain, a kind of C type of pain. When you ask the patient where exactly is the pain, they will be showing a C type of, they will be cupping their hip and showing the pain is there. That denotes the pain is deep inside the hip. If they cannot show it with a single finger, then it is a diffuse deep pain. That is how the hip pain normally presents. And this is a referral pattern of a sacroiliac joint pain. And if the patient has a medial most pain, the medial most deep groin pain, this can be an athletic pubalgia. In a young patient who has a history of trauma and coming with a deep groin pain might be an athletic pubalgia. These are some of the referral patterns of the radicular pain. And this is a patient with a iliopsoas muscle sprain showing a similar kind of anterior pain. These are some of the location of the various bursae around the hip. So almost always, all these cause a clinical confusion whenever you are handling a patient with hip pain. Coming to the common causes of hip pain, it can be, if the patient is in the elderly age group, it can be osteoarthritis of the hip. In the younger age group, it can be athletic pubalgia or femoroacetabular impingement, labral tear or iliopsoas bursitis. Common causes of lateral hip pain or the greater trochanteric pain syndrome, which can be because of trochanteric bursitis, meralgia paresthetica, iliotibial band thickening, or gluteus medius and minimus tendinopathy or tear. The posterior hip pain, the common syndromes are piriform syndrome, ischiofemoral impingement, SI joint pain, and radiculopathy. Coming next to the important part, physical examination. On inspection, the gait of the patient and the stance of the patient is very, very important. When the patient has, sometimes when the patient is made to stand, they may be standing like this, with a gait like this. An antalgic gait might be there, or when the patient is standing like this, they may not bear the weight on the painful hip. So their weight orientation will be different. And when they are made to sit, sometimes they will keep the leg slightly extended to prevent any weight bearing on the same side hip. So these are some of the clues to which hip it is painful, whether the weight bearing is painful. And we have to give importance to the splinting or protective maneuvers, any linear discrepancy, asymmetry between the limbs. Coming to the range of motion, this is very important. So for any patient who comes with a hip pain, testing the range of motion is important. We can do all maneuvers like passive range of motion testing has to be done, adduction, abduction, flexion, extension, as well as internal and external rotation. Coming to the gait and stance analysis, this is the gait. If you see here, the patient is having pain on one side. So he's trying to reduce the stance space on that leg. So it will be looking like he's putting more stance space on the other leg. This is a patient with a, this shows the Trendelenburg sign. Trendelenburg sign is nothing but if the patient is having a weak abductor on one side, the gluteus minimus and gluteus medius, if they are torn, if there is any weakness, if the patient is made to stand on the affected limb, automatically he cannot abduct the pelvis, the opposite hemipelvis kind of drops and the trunk inclines towards the affected side. This is a positive Trendelenburg sign which is useful in abductors of the hip weakness. Then you have the Faber-Patrick's test, which we always do, and the FAIR test. The log roll test. The log roll test is a passive test wherein the patient is made to lie down and just rotate the leg internally and externally. And you have the SLR against resistance, that is the Stinch field test. This shows if the patient is having an athletic pubalgia or any internal pain. So sometimes when the patient is made to flex the leg against resistance, there will be deep pain in the groin. And the seated piriformis stretch test can be done whenever there is a posterior hip pain. This is much specific. The seated piriformis test is almost 80-85% specific for piriformis muscle. The patient is made to sit and we have to internally rotate the hip. The pain will be felt on the ischium. And this is the test, the long stride walking test that is done for ischiofemoral impingement. There are a variety of tests as far as hip is concerned. But the most important thing I would say is the age, any pre-existing trauma, or if the location of the pain. These are the most important things that we need to look into. And all these basic tests, though we are doing so many number of tests, none of these tests are very specific. Almost in osteoarthritis of hip, there will be diminished range of movements. There will be the log roll test will be positive, Faber will be positive, Fair will be positive. So it will be causing a clinical confusion between sacroiliitis as well as hip pain. So we need to further investigate the patients. For if you are suspecting a primary hip pathology, then you have to go for a plain X-ray every standing. You can include the lumbosacral spine as well if you are suspecting a lumbosacral pathology. So any reduction in the joint space, presence of osteophytes, subchondral sclerosis or cyst formation might be showing more towards the hip osteoarthritis. Sometimes if you are suspecting a deformity in the femur or in the acetabulum, you might have to go for special x-rays with special views like Dune views. And the most important test is the ultrasound. You can visualize the joint. There are 3 areas where ultrasound can be used. One is the anterior joint line, the joint area, whether there is any effusion. That can be checked with the ultrasound. And similarly, the trochanteric bursa or the tear of any gluteus medius or minimi muscle, that can be visualized under ultrasound. And in piriformis syndrome, we can do a dynamic ultrasound, which can be diagnostic. So ultrasound plays a key role in evaluating the patients with hip pain. And whenever it is an acute pain in a young adult with pointing towards an intra-articular pathology, never hesitate to go for an MRI. The MR arthrogram needs to be done if there is a labral tear, because this is all an acute problem wherein a hip consultant has to be involved if there is a labral tear, because doing a surgery might be a permanent solution for him. So never hesitate to go for an MRI. And you can, if none of it is like similarly, if you are suspecting a stress fracture or an AVN, then it is better to, early AVNs may not be seen in the X-ray. It is better to go for a MRI. And coming next to the diagnostic intra-articular injection, this is of crucial role. If you are not able to differentiate between hip joint, SI joint or lumbar pathology, then the simplest thing is to give an intra-articular injection in the hip. If the pain settles down with an intra-articular injection of the hip with local anesthetic, then probably the major pathology is the hip joint. There can be coexisting pathologies as well. So it is better to go for a sequential diagnostic injections to pinpoint the accurate diagnosis. So to conclude, a focused history and thorough physical examination is mandatory. If any intra-articular pathology or a sports injury is concerned, MRI, ask for an MRI. And if in case you are finding some acute labral tear, never meddle with the patient. It is better to refer to a hip specialist. And diagnostic injections need to be done to identify the pain generator. These are my references. Thank you.
Regarding the presentation, I thought it's a clinical presentation. I will be getting volunteer, no issues. So I am presenting the slides. Courtesy of the my present institute. So bear with me. I'm also the first time. Let's see how it goes. Evaluation of knees, why it is important, we all know in our clinical day-to-day practice. It is second most common which we often get. Of course, first is the back pain, and the next is the knee pain. And with the advancement of the technology, now we are in the position to manage and treat most of the knee conditions, other than besides the surgical issues. So that is all the more reason that we should know each and every part of examination, assessment, the disease process. So to convince the patient about what we have planned, how we are going to treat, what is the outcome going to be, and what is the all. Then there is a synovial membrane. Another important structure is the patella, which is anterior on the joint side. And all these structures are very important because they become the pain generator, and we should know. We also know it's not only the knee joint and the component of the knee joint, the other areas which are just nearby the knee joint or supporting the knee movement like muscles, ligament, tendons also contribute enough for the pain in the knee. And during examination, we also be examining all those structures in the knee. There are many retinal columns, medial or lateral side, which also contribute to the knee pain, and we also clinically examine them. And of course, when we suspect, we further examine with the ultrasound or other modalities of the investigations. As we all know, the major components are the cartilages, ligaments, we all know ACL, PCL, and the cruciate ligaments. There are menisci, lateral and medial menisci, which are also there. And then very important, the patellofemoral surface, which is very important cause of arthritis and thus leading cause of pain also. So what are the steps of clinical evaluation? Should we start the clinical evaluation as we see the patient? No. As all clinical understanding and teaching, it always starts with the history. So when the patient comes to us, we start with the history because history itself guides us, gives clues that what patient is suffering with, and then we direct our investigation or examination to that particular point. And also remembering the cause of the pain. So when the patient is giving history, our mind is keep calculating the different types and the causes of the pain to be focused on particular examination, and the outcome will be better. So what are the causes of knee pain? We all know the major causes of knee pain are the trauma, degeneration, inflammation, infection, and tumor. And also, like structures which are pain generator, bones are pain generators, but in the current scenario, a lot of sports activities are there, and as we are remaining very active, living very long, so the other ligaments, tendon, muscle, and menisci, bursae, and nerves are also important contributors to the pain. This picture is just showing that when we talk about the causes of the pain, there are different areas which particularly interest us. So suppose some patient is having pain on the anterior or antemedial side, we should know what we are looking for. And these are important causes of the anteromedial pain. So we know, and then we can identify and investigate patient properly. But before we go for further examination, we should know the red flag sign also. The trauma, tumor, fracture, infection, these are all standard red flags. So we should know, we keep in mind before examining the patient and keeping high level of suspicion for all these red flags. For the earlier investigation, what it means, the red flag sign only decreases our threshold for further investigations, and we pick up the cause of the pain. Very important point I just forgot to mention. Whenever we start the knee examination, always examine the hip first. Hip has important structure or cause of pain, referred pain to the knee. So very simply, in the extension we do internal rotation and external rotation, and in full flexion we do internal and external rotation, abduction and adduction and abduction of the hip joint. And if there is a pain, that may be a very big contributor to the knee pain. Now there are certain special tests when we have done the general examination, physical examination, inspection, palpation, and the movement examination. Then we come to the special test. So the test for the medial and the lateral collateral ligament test, this is the stress test we call it. When we pull the leg to the lateral side, so what we are doing, we are stressing the medial collateral ligament, and we palpate here. If we feel pain, then patient might have had some injury or partial tear in the medial collateral ligament. But if there is too much laxity, it may be a totally torn medial collateral ligament. Similarly, lateral collateral ligament, the same stress tests are done. We can also do the rotation test, like holding the thigh and try to rotate the leg and displace medially or laterally. So if the collateral ligaments are laxed or traumatized, if they are partially traumatized, patient will have the intense pain, or some relaxation is there, which give a abnormal movement or abnormal relaxation or the laxity on that particular area, medially or laterally. Now there are certain special tests for the patella which indicate the patellofemoral abnormality or arthritis. One of them is the tracking. What we do, for the tracking, we flex the knee, hold the patella, and then extend the knee. Actually, in a normal way, the patella should not go lateral or medial. But in abnormal situation, when there is a patellofemoral dysfunction, the patella moves laterally outwards, and this is known as the J sign. We also do the subluxation test. In simple flexion of 30 degree, we try to subluxate the patella medially or laterally. Usually, it does not go beyond 1/4 of its position. But when it is subluxated, it can be moved too much either medially or laterally. Development test I have already explained. Now patellar grind test, which is again indicating of patellofemoral arthritis. We fix the patella by holding the patella and then ask the patient to tighten the quadriceps. So it pulls the patella. If there is a crepitus or pain, then it indicates that patient is having patellofemoral derangements. Like as you can see here, this holding the patella from the upper pole, and we are pushing the patella. This can be done actively from here, or we can ask patient to contract the quadriceps. In both the situation, either crepitus or pain is felt, and this only indicates the patellofemoral dysfunction.
Sir, can you please finish a little earlier?
Yeah. For the ACL, we know the anterior draw test we do. The knee is flat by 90 degrees. The holding the shin and we pull forward. So if ACL is traumatized, there is a abnormal softness at the end point. If ACL is intact, then normally it is not pulled forward. Another test for the ACL repair is the Lachman test. It is better than the anterior draw test. It's a modified form of the anterior draw test where the thigh is fixed and then the shin is pulled forward. So if there is a laxity in the ACL, you can see the soft end point, that the shift of the tibia is quite soft. And if it is totally relaxed, we can say the ACL is completely teared or it is a partially teared. There are other tests also like pivot shift, or for the PCL, simple observation that there is a lag in there. In the PCL, the posterior draw test, we push like in anterior, we are pulling it, and in posterior, and there is some softness in the posterior pushing. and the end point, and that shows the posterior PCL tear. SEC test, in which patient they simply keep the 45 degree both the knees, and we see if the PCL is tear, that particular side of tibia is sagging behind. For the meniscal tear, we do the McMurray's test, which is nothing but the stress test for the medial or the lateral menisci, where the pain, when for the medial meniscal tear, we palpate it and then internally rotate, and for the lateral meniscus, we externally rotate, we feel pain in the medial side or lateral side. That is how we know that the which meniscus is painful. The Apley's blind test is also done in prone position. Again, is the stress test, the patient in prone position and pushing back and rotating, and the side of meniscal tear will be painful. This is another Thiesler's test done for that, but one has to be very cautious because patient is standing on one leg and affected leg, patient will fall down. So I'm just finishing. It's the last minute on that. Thank you very much.
Good morning, all of you. Last lecture of the morning session, and thanks to all my previous speakers who have done a great job so far. So my job is half done actually, so I'll try to cover it in 15 minutes. Okay, so foot and ankle is the last one. So when we talk about the examination of the foot and ankle, it is complicated. Unlike knee, shoulder and hip, so we have 26 bones, 33 joints. And if you combine the muscles, ligaments, tendons, so there are more than 100 of them. So just imagine when you walk around 10,000 steps per day on an average, around 1 million of steps per year, and 115,000 miles in a lifetime. And when we run, we put 3 to 4 times of our body weight on our foot and ankle. So that is the amount of stress, wear and tear, the strain that the foot and ankle joint has to undergo, leading to a lot of myofascial, musculoskeletal, ligament, tendon, and the osteogenic causes for the foot and ankle pain. So before going into the cause evaluation, I'll just briefly talk about the anatomy. Like any other part, like the hip, anterior, lateral, posterior, medial. Similarly, foot and ankle, when we talk about it, we kind of divide into 4 phases. Anterior, medial, lateral, and the posterior ankle. So here in the anterior, one can see the tendons, anterior ankle here, the tibialis anterior, extensor hallucis longus, extensor digitorum. Those are the 3 muscles and tendons. On the medial side, the tibialis posterior, flexor digitorum longus, flexor hallucis longus, the tarsal tunnel nerves, the ligament there on the top. Coming to the back, the gastrosoleus, Achilles tendon, and on the lateral side, the peroneal group of muscles and the tendons. Okay, so again on this medial side, this is the tibialis posterior, flexor digitorum, and flexor hallucis longus tendon, the flexor retinaculum there, lateral side peroneal tendons. Coming to the ligaments, the medial side, it is the deltoid ligament. That forms the most important ligament, which is a combination of superficial and the deep ligaments. On the lateral side, this is the anterior talofibular ADFL, the PTFL, and the calcaneofibular ligament, which provides stability and strength to the ankle joint. Plantar foot is important. We see most of the patients on the foot and ankle is the plantar fasciosis. This is the plantar fascia, the digital nerves. So these are the bones actually, tibia, fibula, the tibiotalar joint, the talonavicular, calcaneocubert, the cuneiform. Okay, so this is really complicated, just to have an idea in case you have forgotten the name of the bones. So whenever a patient comes to us with foot and ankle symptoms, usually with pain, swelling, deformity, stiffness, instability, and abnormal gait. So these are the things they present to us. So coming to any examination, not only the foot and ankle, this applies to the pain medicine per se. OPK or ST, which has been discussed so far, onset is kind of when did the pain start, provocation or palliation, aggravation, and the reduction factor, the quality of the pain that will give you an idea about the nociceptive or the neuropathic or the mixed component of pain, radiation, does it go anywhere, severity that we all time do, and temporal factors. Another acronym is Socrates, that all those young pain people can cite, onset, characteristic, radiation, associated symptoms can be, the exacerbation and the severity of the pain. So coming to the brief overview of the etiology of the foot and ankle pain, because if you talk about the foot pain, there are a lot of other causes which can be of importance to sports medicine people like orthopedic surgeons. But for us, for the pain physicians, I have kind of figured out few of the causes according to the location: anterior, medial, lateral, posterior, and the heel pain. So anterior ankle pain can be from the degenerative arthritis. When you talk about the medial or the posterior medial, just imagine, so we have the deltoid or spring ligament there, and we have the tarsal tunnel with the tendons of the tibialis posterior, flexor distrum longus, flexor hallucis longus, the tenosynovitis, tendinitis can happen, and oftentimes the rheumatoid arthritis that also affect the ankles equally. You can see a lot of effusion, synovitis there also. Coming to the posterior, it is the Achilles tendinosis, retrocalcaneal bursitis, and the tear. The Achilles tendinosis again variety mid portion of the distal insertional calcific, the Hegland deformity, and so on. Posterolateral, it is the peroneal tendons that commonly gets affected, and coming to the lateral, in terms of trauma, ATFL, the stress fracture of the distal fibula, sinus tarsi syndrome, and the subtalar joint. Those are the commonly affected. Coming to the heel pain, that forms the bulk of the patients that we see, the plantar fasciitis, calcaneal stress fracture, fat pad rupture, and keep this thing in mind, Baxter neuropathy. Okay, so this is one cause of the heel pain that is often ignored. Coming to the midfoot, degenerative changes, arthritis, Lisfranc injury, tarsal bone stress fracture, peroneal brevis tendon insertion on the base of the fifth metatarsal, okay, on the lateral side. Coming to the forefoot, the common one, the Morton's neuroma and the metatarsalgia. And the final one, the big toe that commonly gets affected in gout, in sesamoiditis, hallux valgus, or the bunion. Sesamoiditis is one thing, keep that in mind. So recently I saw one of the knots in our hospital having the plantar part of the foot pain, and exactly at the MTP joint, she had a sesamoid bone, severely painful, so she was not able to walk. I just gave a ultrasound guided injection below that sesamoid bone, just 10 milligram of diprometal. That was the end of the pain. Okay, so keep this thing in mind, sesamoiditis. Important history, that again has been talked so far, specifically in foot and ankle age, occupation, any participation in the sports, specifically most of the injury that happen, talk about the young people and the athletes, sports, history of low back pain. Don't forget, good number of foot pain can originate from the back pain also. Some of the SI joint pain, radicular pain also can from the back pain. History of pain in other joints, kind of migratory patient who have diabetic, talk about the diabetic neuropathy, vascular disease, inflammatory arthritis, rheumatoid. Keep all these things in mind and take history about these things while taking history also. When patients come to us, also the next thing is look for deformity. When did the deformity start? Duration of the deformity, is it progressive, static? Any associated symptoms with deformity also. Coming to the swelling also, good number of patients present with swelling in addition to the pain. So find out if swelling is unilateral or bilateral, if the swelling is localized to one part, or it's generalized. It can be of systemic disease, cardiac, some liver failure, anemia, nutritional deficiency also. So keep those things in mind and evaluate accordingly for the swelling. Does the swelling get aggravated with activities? Is it there at the rest? All those things matter. Duration and frequency also importantly. And most importantly, before you wind up your physical examination, don't miss the red flags. Like trauma, tumor, any night sweating, fever, weight loss, chronic corticosteroid use, numbness of the foot, paralysis of the limb, any infection and so on. The clinical examination is background of history and anatomy and history taking. So the moment patient enters to your room, so that is the first point you look and take the history. The way patient enters, how's the gait? Is the patient able to walk properly? Is the patient using any kind of gait, walking aid or wheelchair? So that gives us information about many things. Look at the facial expression of the patient also. So first thing, we look at the in a sitting position, inspection of the foot and the footwear. If the patient is using what kind of foot, outer side, inner side is getting worn off, and if the patient is using any kind of orthotics, any kind of insoles, does that insole help or doesn't help? So how does the foot look like also? Okay, and the next one, you look in the standing position. Make the patient stand and examine the whole lower limb as a whole, not only the lower limb as well as the spine also. So look for the knee for the varus or kind of valgus deformity, but also because that also affects the implantation of the foot also. So So look for the spine, pelvic tilt, look for the calf muscles, if it is normal or there is a wasting of those muscles. Look for the heel arches, is there a kind of normal arches maintained or is a flat foot or kind of a pes cavus also. Look for any swelling, previous surgery, scar, anything of that sort. Look for the toes and other parts. And then towards the end, make the patient walk on the toes as well as on the heel and the side walking. So that will give you information about many things. And in deep toe walking, you can assess the ankle flexibility, impingement, the function of your Achilles tendon, tibialis posterior muscles, midfoot. So similarly, when patient is walking on the heel also, you can look for the anterior impingement, tibialis anterior function, all those dermatoball distribution, muscle function. So as a whole, that will give you a lot of information about the muscle, tendon, ligament, and joint alignment in total. And the next part of the examination, once this part is done, the next comes your range of motion, strength, palpation, and special tests. So ankle range of motion, so we have like dorsiflexion, plantar flexion, inversion, as well as the eversion. So look for this range of motion if there is any restriction of those things. Once this part is done, look for some examination of the muscles. Typically for the anterior part, we have the tibialis anterior, flexor digitorum longus, extensor hallucis longus, and extensor digitorum longus. So tibialis anterior gets inserted into this medial cuneiform there, and it helps in dorsiflexion as well as the inversion of the foot. So you do that in maximum dorsiflexion and inversion. Try to do a plantar flexion and tell the patient to resist and feel for the contraction of this tendon over there at the medial cuneiform for the tibialis anterior. Similarly, for extensor hallucis longus, we know that extends the big toe for the L5. So tell the patient to do the resisted extension as you feel for the contraction of the muscle. Similarly, for the EDL, it extends the lateral all the 4 toes. So do the extension of that with resistance being given. Tibialis posterior, which goes in the tarsal tunnel just behind the medial malleolus. So that helps in the plantar flexion as well as the inversion of the foot. So while you put resistance and try to do a lateral movement, feel for the tibialis posterior tendon here on this just below the medial malleolus to see for the contraction of that tendon itself. Similarly, peroneal muscles, again on the lateral side, peroneus brevis and longus, just posterior to the lateral malleolus. So look for the outward eversion of the foot while giving resistance and feel for the tendon just behind lateral malleolus here. So these are basically for the muscle strength and examination. And now look for some of the special tests. One of the special tests is the typically young people that come out who have sports injury trauma is the anterior DOAC test, that is for the ATFL, anterior talofibular ligament. So basically you squeeze the distal tibiofibular joint there and tilt and give a forward thrust or forward movement of this foot joint, and you can feel that joint moving there easily, and the formation of a sulcus just anterior to the lateral malleolus. That gives a positive sign for the anterior DOAC test for the ATFL. Similar, another test for the ATFL anterior talofibular is the talar tilt or the inversion stress test. So you hold again on this side, give an inward pressure on this side, holding the ankle itself. Try to do as much inversion as possible. If there is a more inversion or the patient feels pain, so that gives a positive signal that ATFL is possibly torn or there's just pain of that. Commonly in the history of trauma or a patient who had undergone corticosteroid, blind corticosteroid injection, so there's a possibility of Achilles tendon rupture. So when you squeeze the Achilles tendon here, the mid calf area, your foot, what happens, your foot kind of goes for a plantar flexion. Okay, so whenever you squeeze that, so that becomes absent. So that is a positive Thompson sign in Achilles tendon rupture, and that can be easily identified with ultrasound. Another thing we see the forefoot pain is the metatarsalgia or the Morton's neuroma, typically affecting the 3rd and 4th web space. So you squeeze the forefoot there, and on the 3rd web space you can feel the popping of the neuroma coming out of that web space itself, and patient feeling the pain. So that is a positive test. Next one, the common thing that we should not miss is the plantar fasciitis, the heel pain. So commonly that sees in the obese, those who stand for a long time also. One of the things also one should keep in mind that all heel pains are not plantar fasciitis. Here, typically, if you look at this area, so 3 and 4 are the areas, 1 and 3 are the areas where typically the tenderness is there. So that suggests that it is the plantar fasciitis. here are the 4 areas of fat pad rupture. Keep this in mind, the number 2 location, this medial calculate diversity, that could be, if there is a tenderness and reproduction of the pain, so possibly there is a Baxter nerve entrapment, which is the first branch of the lateral plantar nerve that goes beneath these 2 muscles, the abductor hallucis and the quadratus plantae. Any kind of tenderness over this area, and sometimes the pain can radiate to the lateral tooth. Keep this possibility in mind. In around 10 to 20% of the patient who had heel pain or the plantar fasciitis also, they can have this Baxter neuropathy. In patients with plantar fasciitis, Baxter neuropathy can coexist as well. Okay, so this is a kind of paper we published. One can identify this tiny nerve and go for the procedure. And finally, we can do that neurological test, sensory testing in different kind of dermatomal distribution of the 5 nerves of foot and ankle, and look for any kind of neuropathy, because sometimes, diabetic neuropathy, radiculopathy also, post-surgical pain, foot and ankle can happen. That can be very much ascertained. Final part, last 1 or 2 minutes. So I strongly believe that your clinical examination for the foot and ankle pain is incomplete without doing a musculoskeletal ultrasound examination. That can give a lot of information about your what about the provisional diagnosis thought of so far from the history and clinical examination, that you can arrive at a good number of diagnoses. So for again, like any part, we have this checklist. So you can do an anterior ankle examination, this anterior stays, again looking for the short axis in the tendons of the anterior knee, anterior ankle here. Medial side, you can very well see this tibial posterior, the tarsal tunnel, tibial posterior, flexor digitorum and flexor longus. The tibial nerve that again branching into medial and lateral plantar nerve, giving rise to the first branch of the lateral plantar nerve. Just a minute, I'm done. Okay, and then again you can see this tibialis posterior tendon also. In a lot of rheumatoid arthritis, you can see tenosynovitis happening over there. So you can scan in the long axis till its insertion into the navicular bone over there. Similarly, you can assess also with a little bit of experience and scanning. You can see the ligament complex also, the medial side, the deltoid ligament, and then the lateral side also you can see this lateral ATFL ligament, anterotalofibular ligament, which commonly gets affected also. So you can see that very well with the ATFL, and that can help you the talar tilt, the anterior test I talked about. Achilles tendon again can very well you can see the insertional tendinosis, the calcification, any kind of Haglund deformity, the retrocalcaneal bursitis also. So suppose here in just I'm giving these slides to have some impression. Have a look at this. It's a tibial joint effusion over there, typically seen in patients with rheumatoid arthritis. Okay, suppose you get some kind of patient like this, you can diagnose and do the procedure then in the OPD itself. So this is again just to show the synovial hypertrophy, Doppler signals also in patients with rheumatoid arthritis ankles. In gout also, we can see the double contour sign very nicely over the first MTP joint. This is a picture of retrocalcaneal bursitis. Tibial posterior tenosynovitis, nicely we see that quite again, this is a patient with rheumatoid arthritis. So my take-home message will be history taking and clinical examination forms the significant component for the foot and ankle pain. Keep your differential diagnosis to few things at the end of your examination. And if you have ultrasound in your clinic, nothing like that. It can help you in arriving most of the diagnosis. MRI, if you order, what I have found, they give you some of the non-specific things, a lot of degenerative changes, ligaments, some tears, some kind of stuff also, which actually never are the pain generators. On the patient having pain on the medial side, but on the lateral side, a lot of changes will be there in the MRI. You'll be confused at the end of the day what to do. So thank you very much for your kind attention. Thanks again.
And if there are any questions.
The assessment in the clinic, if I find any difficulty. A lot of patients, they do have some kind of this foot and ankle deformity, like a little bit of valgus, varus also. Patients with like 50 plus also, they do have knee arthritis also. In the clinic also, we have a couple of days of multidisciplinary clinic also with orthopedic, with rheumatology people also. Then we have orthosis people also, who deals with this kind of stuff also. So we make sure that I send all of my patients to the patient who deal with all those kind of ankle, foot and ankle devices to make the alignment normal also. So in terms of like test, we do a scanning of the whole knee. Also those do have kind of knee arthritis, so whole knee or whole HP axis scanning in standing axis just to see the alignment. Apart from that, I think the clinical examination, the neurological stuff also, ultrasound and kind of multidisciplinary meeting that we do. Difficult cases, not all the time, 1 hour, we do that in Wednesday and Friday also. So difficult cases, we discuss about that. But apart from that, not specific any kind of days. So coming to that kind of treatment, what I found, more than 80%, 85% of the patient with plantar fasciosis, they respond well to corticosteroid injection. I do still use corticosteroid. I recently gave it to myself to tell you that I am wearing a gel also. So a lot of patients respond very well. PRP is painful actually. Some of the patients they call middle of the night also, unless it is very compelling. I do PRP also, but a good number of patients with my technique, what I have received, 3-5 year history of plantar fasciitis, won't believe patients were seeing a rheumatologist who was taking all kind of DMARDs, biologic also, without nothing, everything was negative. I was surprised, and those patients I did 1 injection, some 4-6 months ago, 80-85% of better also. So corticosteroids, they do help in chronic plantar fasciosis, and as I told, this Baxter neuropathy, keep this in mind also, that is something very underdiagnosed, undertreated cause of the heel pain also, it can coexist. Sometimes I do combine that Baxter nerve injection also, just 1-1.5 ml in addition to the plantar fascia also. Thank you. Welcome.
About 11 in the international and national journals, and he's been the organizing secretary of Pain Calcutta 2015 and 16. We welcome you to the session. Thank you.
Thank you for welcoming and such a nice introduction. So today I'll be talking about the ESG neurology and a little bit clubbed with the physics as well, because what I feel, always you know what is going behind. It is not the keys only. So first of all, the transducers. So what we have commonly in musculoskeletal ultrasound, we use 2 types of transducers and sometimes some of the variations of those transducers. For example, we have the high frequency transducer that usually commonly what we use is up to 6 to 12 or 6 to 15. But we have some ultra high frequency transducers as well. Like here in this machine, I think we have a robotic probe that goes up to 22 megahertz as well. So what is the advantage of using this transducer? Mainly, it is for the superficial structures. Superficial structures, we can see much clearly, because in these transducer, resolution is comparatively higher. Then what is the resolution? Resolution means number of small dots that is actually combined to form that image. If the number of dots are more, you will be able to see a more clear picture. And it is less, you will be seeing a less clear picture. So what happens with this high frequency probes, usually we get a more resolution of pictures. But again, it is not the only factor that determines the resolution, because focus also plays a very, very important part. Now coming to the low frequency transducer, here the advantage is penetration. So if we feel any structure which is at a depth of more than 4 centimeters, it is usually considered, but it is not fixed. Okay? So in those cases, we need a more penetration. But more penetration comes at the cost of the resolution. Okay? So here we will be seeing a comparatively blurred picture, because the number of pixels will be less per inch, or you can say per unit area, and this will be helpful for the deeper structures. So first knob that we need to do is the transducer selection knob, and depending on which area we want to scan, we have to change the transducer selection knob. These are very simple, like switching on your remote in the TV. It's not very difficult thing. Now, how to understand which one is linear and which one is curvilinear? Simple way, the end of the transducer is flat like a rectangle in the linear array. Sound waves that comes out of the transducer is exactly perpendicular. So what does it mean? It means that whenever we are getting a straight like a box-like appearance in the ultrasound screen, it not be a trapezoid view. Okay? So here some advantages and disadvantages are also there. Because of this view, what happens, whenever you are putting needle, you have to be very careful that your angle of the needle. If it is more acute, then what will happen? All the echoes will be reflected out of your brain. Okay? So you will not be able to see a good needle view. So there are options by which you can actually steer these beams. So with the linear probe, you have an additional button of the steering. Steering helps whenever we are doing a procedure to keep the needle. It is not unlimited way that it can compensate, but for certain degrees it can compensate your needle movement. And less anisotropy, limited field of view, and definitely good for the superficial structures. Whereas the curvilinear array is end of the transducer is curved, sound waves are emitted in a fan-like structure, and definitely you are getting a larger field of view. Especially some conditions like when you are seeing at the trigeminal branches, then curvilinear array helps us a lot. So these are the pictures of these two types of transducers. Now, transducer positioning, this is not exactly a part of the knowledge, but we have to know it because it is also very, very important to get a clear picture. So, first of all, transducer should be flat on the skin surface, and examiner's hand should always be on the skin surface. What happens when we found the new persons, new students were coming to us and trying to learn ultrasound? I always found they're holding the probe like this. Some holds the probe like this. But remember, in ultrasound, if we just change an angle, a very small amount, it changes the field of view and the quality of picture a lot. So always stable your hand against the body of the patient and then you move the probe. Do not hold it like a way that you cannot hold it comfortably. And the angulation is also very, very important. That means our patient should be at the middle, one side it's my eye and just opposite side is my skin. So that should be in a single line. And with my left hand I can control the knobs. This is very, very important. Otherwise, in ultrasound, it is always very, very difficult and back pain is very common for the operator. So you have to sit, you have to take time, you have to be comfortable and then do it. Another thing is very, very important is the maintaining proper pressure. Because if you do not put proper pressure, what will happen? The veins will be breached. Okay. Even if you put more pressure, you can breach the arteries as well. So unless and until you have given the proper pressure, what will happen? That you will not be able to structure there. This is very true for the superficial vessels, like you want to flow focus the saphenous. In those cases, you can use a gel standoff technique. So that you put a lot of gel, especially where the skin surface is not smooth, like ankle. So you have to cover a depression. Then also put ample amount of gel so that the gel makes the surface a straight surface. Okay. Avoid involuntary movement of the transducer. Definitely, if you are fixed properly, then you will be able to do it. Allow fine adjustment of the transducer positioning. Now, short axis, long axis, that will come and that will be explained many times, so I am not going to this part. Transducer handling is also very important. Two things are important. One, we need to know the movements. One is the heel toe movement, but if this is the transducer, I will be moving like this. Waggling and rotation. These three movements is very, very commonly used and you have to do it properly. Next, come to the depth adjustment. So all the ultrasound machines is having a depth adjustment button, or here it's a screen. So the button will come on the screen, and this helps to increase and decrease the depth of field of view. Remember, it is different from focus. It is not the same thing as focus because it totally decreases or increases the depth of the field. Okay? So when we are seeing a superficial structure, we should make it towards the superficial side. And when it is at a deeper structure, we have to increase it. And when it is going much deeper beyond the linear transducer, you have to go for the curvilinear transducer. So depth of adjustment is very, very important. Now, focal zone adjustment. Here, the concept is a little difficult. For the light rays, it is very easy to understand what is focus. Okay? And I think you all know, you have learned in the physics. But light rays are the rays that actually can be easily focused by the convex or concave lens. But here, how is the mechanism? Because it is a sound wave, and sound wave propagates in only one direction. Okay? It is not that multiple beams are coming. Here, multiple rays of beams, echoes are coming, but they are all moving towards, they are the linear waves. So linear waves cannot be focused in similar manner with the light rays. So there is a special mechanism, which is known as serial firing. So how this serial firing occurs? Remember, in ultrasound what happens? It is not a continuous echo, it is an intermittent echo. First firing occurs at the peripherals, then the firing, this is in a very fraction of a millisecond, then the firing comes at the center. So that it can focus, the beams can be accumulated in a small area. This is one technology that is adopted by certain manufacturers, and certain manufacturers do what? It is the differential reception. Okay, that means the central they will be receiving early, the peripheral they will be receiving slowly. So ultimately making the ultrasound beam a beam that is a little constricted at a definite focal point. And we have to keep the focal point to that structure. As the beam is constricting, what is happening? The resolution at that area increases. So this is the mechanism by which actually the ultrasound machines do this focusing part, and this part is a trade secret of the companies. So how they are doing, not all the manufacturers report that. It is their trade secret. So for the good machines, this mechanism is far better than the inferior quality machines. Now coming to the gain adjustment and time gain compensation. So what is gain? It is basically how much bright or black one structure is being seen. So if we want a structure to see more contrast or more gain, then what we do? We can increase simply the total gain. But if we require a certain area of the scale to be more bright, then we can go for this right-sided thing that is shown in the upper part, that is the time gain compensation. But here is the question, instead of differential brightness or differential contrast, depth-wise contrast, why the name is time gain compensation? The question came to my mind as well. What is the compensation? What is time? What is gain? The concept behind is that when our echo is firing at the near the screen, that means superficial part, what will happen? The echo that is going, the amplitude is higher, and what is being reflected from the tissues, it is also higher, because the attenuation within the medium is less. Now, as we are going to a deeper structure, what is happening? Here, the echoes will take more time to go and more time to come, but these echoes will be more attenuated because they have to cover a longer distance to enter to the structures and come back. So, the machine gives us an option that these deeper echoes we can compensate, and specifically compensate at a certain area. And this is one mechanism is runs as a global gain that happens through the machine automatically, and one is the focal gain of an area, and that is this portion. And remember, a lot of students initially do a mistake that they put all the transducers the right side. So the same thing you can achieve by increasing the global gain. So this is a specific mechanism if you want to make any specific area darker or brighter. Okay? And related to this thing, one adjustment also here that is known as the dynamic range, in which it means that like our this thing, what we say, camera. So they can, our eye, the dynamic range is very high. We can see bright to very dark. But in case of camera, we have to adjust the exposure and the shutter speed so that our range is limited. Here also, all the machines working under a limited range on which these echoes can perceive. So they have this dynamic range compensation as well. Okay? So what happens if we increase this dynamic range? Then your grayscale leveling will be increased. So gain adjustment is very, very important thing. And if you make the adjustment gain properly, then you will be able to see the structure best. And one thing here is very, very important, that when you are seeing a structure under any depth, the image not only depends on that structure, but the surrounding structures as well. For example, if you are having a bright light behind you, and now I am taking your picture in front of the bright light, what will happen? You will look dark. Okay? And if the background is very, very dark, and there is a light on you, and you will be more white. Okay? Similar thing happens here as well. That means when a nerve is closer to the structure that is more hyperechoic, for example tendons, then the same nerve looks hypoechoic. But when it goes inside the muscles, then it will become hyperechoic. So that is why sometimes we say median nerve at the rest is hypoechoic. But as we go a little up, it becomes hyperechoic. So you have to understand this. This is relative, and this adjustment the machine is doing every time. It is a continuous process with the machine. Okay. Bring back the presentation. Okay. So I was there in the gain adjustment, and these are the basic things. I am not telling that you are having a lot of adjustment, but initial part, these are the things that you need to do. Do I have time to show it in the machine, or I have time to go to the next? Okay, then let's go for the next. But definitely, when Dr. Das will be doing scanning, I will check in the machine also. I will show in the machine as well. Okay? Thank you.
Supraspinatus muscle is easily visible, as I had shown in my pictures. I can take. No problem. I will. Please, sir. Please. When we keep the probe in this position, what are we going to? Can I have the laser? Laser point. When I keep the probe in this position, this is the position. This is the modified class position in our patient is. If you keep it in this position, and if you keep the transducer in this position, this is the supraspinatus picture that you come across. This is the head of humerus, this is the supraspinatus, this is the deltoid. Now, if there is tendinosis, you can see it. If there is a bursitis, you can see. If there is any problem with the deltoid, you can also see that part. A normal examination of supraspinatus is this, but not well fully seen, so you have to keep it in modified class position, so you see this kind of a picture. The other thing that we have to see for tears also, this is again the modified class position. In modified class position, you can see the partial tears as well as complete tears. If you want to see the greater trochanter and the lesser trochanter, what you have to simply do is, for bicipital groove, you ask your patient to keep the arm in the supine position and stand behind and keep it on the bicipital groove and keep it in this position. If you keep it in this position, what you come across is, if you keep it in this position, this is the picture that you come across. Your probe is here. This is what I have shown you. This is the greater trochanter. This is the lesser trochanter. This is the long head of the bicep. You don't have to keep it oblique. If you keep it, instead of keeping it straight, if you keep it like this, if you just rotate it, I'll move my arm so that you can see it. Instead of keeping it like this, if you keep it like this, then you will see an anisotropy as I had mentioned previously. This is the anisotropy which I was talking about. Now, what happens is sometimes if you move your probe rather than keeping it here, if you move it quite proximally. Proximally means, I mean to say here. If you keep it here, then you start seeing the rotator cuff interval. You don't see these two mountains and this valley. You see this kind of a picture. So this is the rotator cuff interval. Now, so in this picture, this is also seen with no problem with this picture. Now, if you want to see the acromioclavicular joint, acromioclavicular joint, though it is a joint between the clavicle, just feel for the clavicle, feel for the acromion. Don't keep your probe like this on the acromioclavicular joint, you will not be able to see it. You have to keep it, don't keep it like this also, you have to keep it slightly inclined. And if you are not able to, you will see a V shadow of the acromioclavicular joint. So this is the rotator. If you are able to see this screen, I don't know whether you are able to see. Yeah. So in this position, you are seeing the rotator cuff interval. This is long head of the biceps. This is your greater trochanter. This is your lesser Again, we'll do a modified class examination fast. So in modified, this is the picture which you have to see. You are seeing the head of the humerus, the supraspinatus. This is exactly the same epigenicity. You can see the fibrillar pattern of the supraspinatus. This is the deltoid. With the island epigenicity, so there is no tendinosis. It's a normal supraspinatus muscle. So then, if you want to see the bicipital groove, keep it lower down, start moving it up. This is the bicipital groove. Now you can see the greater trochanter, lesser trochanter. Can you please the picture? Can you please? Yeah. This is the greater trochanter. The greater trochanter is outside, lesser trochanter is inside. This is the long head of the biceps. If it should be placed centrally. The contour should be normal. There should be no anechoic island here. So this is the examination. You can also, can you unfreeze it, sir? Gaurav, please unfreeze it.
Reduce the lights,
please. This is, you are seeing the long head of the biceps. See, very nicely now you can see the long head of the biceps and the ligament, ligament also. Now you slightly move it in the long axis. Now you are seeing the tendon in the long axis. the long head of the bicep, these small synovium surrounding it, superiorly, inferiorly also. So you know there is no tear, there is no injury, there is no tear inside. Right? Can you see? Can you appreciate it? Okay. So this is the thing. Now the next thing that you're going to see is the acromioclavicular joint. To palpate the clavicle, palpate the acromion, and then this is the acromioclavicular joint. Can you see that deep part? Please. Okay. So yeah, thank you. So this is the acromioclavicular joint, and this is one end of it, and this is the other end. This is clavicular, this is the acromial end, this is the joint, this is the normal cavity of the acromioclavicular joint, and so you can examine this joint. We are seeing, and if you want to do a dynamic examination, what you've got to ask is. Just see this. Just see this joint. It is more than 3 millimeters. The acromioclavicular distance is more than 3 millimeters. Please have to do shoulder. Now gradually you are seeing that the distance is reducing, but still the distance is not reduced more than 1 millimeters. So there is no acromioclavicular injury, ligament injury. So this is a normal acromioclavicular joint without any pathology. Now the synovium is also normal. The joint in this position, this is the joint. This is line. This is the synovial part. This is the ligament part of the joint. And we have seen the dynamic examination that this distance did not reduce by more than 1 millimeter. So it's a normal acromioclavicular joint. Now the other thing that we're going to examine is the subscapularis. Now, again, please. Now, what is happening is that this is the long head of the biceps, this is the rotator cuff interval, this is the subscapularis muscle, this is the supraspinatus muscle. Now, we are going to examine this muscle, whether this muscle, this is in the normal position, this is the normal position. Now, we are going to see till what extent this muscle dips and whether there are any tears in the subscapularis also. So, we can see that part also. Yeah, now we are seeing the probe. So now you are seeing. You're seeing that the probe of you see this tendon of subscapularis is dipping down. It is dipping down to less than 9 o'clock position. So it's a normal, and when you keep it in this position, you are finding the whole subscapularis. This is the subscapularis.
We are going to start with the anterior angle. So if you remember the image what I had shown, we'll start from the anterior side, just doing the holding landmark. So this is the lateral malleolus, this is the medial malleolus. Just in between, you put your probe and try to identify the key structures. Can you see that?